Welcome, everyone. Thank you for joining us for our Lewy body dementia webinar series. The topic for today is managing daily activities and fall prevention. Our original topic had included sleep disorders, but this was covered in our previous webinar, which can be found on our website. Today, we are lucky to be joined by two great presenters who have lots of experience working with family caregivers and being a caregiver themselves. There will be a Q&A session at the end of this talk, so please feel free to write in your questions in the Q&A box at the bottom of your Zoom screen. And with that, I'll hand it over to our presenters, Sarah Dulaney and Helen Medsger.
Thank you, Manor. Let's see if I can advance these slides. All right, my name is Sarah Dulaney, and I'm a geriatric clinical nurse specialist at the UCSF Memory and Aging Center. I've been working with patients with Lewy body dementia, both at the VA in Palo Alto before I came to UCSF, and with the UCSF team since about 2014. The main focus of my work is on providing education support and care coordination for patients and families living with dementia through the Care Ecosystem program.
Hi there. Good afternoon, everyone. I'm Helen Medsger. And as you can see from my bio, I've been caregiving individuals with Lewy body for over 30 years. I have 3 first-degree relatives who have passed from the disease: my father, my sister, and my youngest brother. Because of my journey with them, I thought it was very important for me to share with all the caregivers out there my journey. I don't want you starting from ground zero as you navigate this disease. So I hope that the information that Sarah and I present today will provide you with some guideposts. So we're going to be talking about managing daily activities. The first thing we need to look at is why establish a daily routine? Well, number one, it's important to support your loved one's autonomy and maintain function for as long as possible. Although your loved one has a diagnosis of a progressive neurodegenerative disease, it doesn't mean that the disease must define who they are moving forward. So as their care partner, I recommend that you consider yourself in a supportive role. You're working side by side with your loved one, and you're assisting them to maintain as many physical and cognitive abilities for as long as possible. The second is to accommodate for the loss of executive function, apathy, the issue of daytime sleepiness, and many people suffer from anxiety. So if you assist them to consistently set up a daily routine, you can help your loved one have a real sense of purpose and really help them attain goals on a daily basis and throughout the disease. So let's look at what you as a caregiver need to do. You need to first off adjust your expectations and adapt your approach. Let me take this quote from Wendy Lusbader. Knowing what to do with an ill person with dementia and what to cease doing begins with understanding what life is like from that person's perspective. So I want you to take a few moments to put yourself in your loved one's shoes. How has Lewy body disease changed their daily life? Physically, their movement is slowed, their vision is impaired, their balance is off. Many of them may feel like their body has betrayed them. The next, cognitively. They obviously process information slower. They no longer recall the steps to execute a familiar task. Is their memory impaired? And sadly, many have insight into these losses. Socially, have they had to leave their employment? The most important, have they had to give up driving? Are their friends still including them in activities? Are they still able to enjoy their daily hobbies? I want you to not only acknowledge to them, but acknowledge to yourself that life will have a different course than what the two of you may have planned. But our role as care partners is to support them so they may be able to maintain as much of themselves as possible and adjust with them as the disease progresses. Next slide. Now that we've established why a daily routine is important, let's discuss how to make it happen. So, how do you establish a daily routine? First, observe the person's existing habits and preferences. If your loved one is in early stages and still able to participate in the process, sit down with them and discuss what their daily goals might be. Acknowledge that although there are changes, obvious changes, you're there to partner with them to design a routine that maximizes their capabilities. Next, observe them in the home environment, and then again when they are out in social settings. What brings out the best in them? What in the environment triggers positive responses? And also what triggers negative responses? Are there safety concerns that you need to be aware of? The next is use tools to help you stay on track. There's a lot out there these days. What format works best for them? Could it be a written list, a spreadsheet? My favorite was always a dry erase board or a large format calendar. How about a scheduling program on their cell phone or tablet? And don't forget to set the reminder tones. Might be a smartwatch, pill reminder alarms. There are so many options out there now. Find out what suits your loved one the best. But remember to start simple. Start with the discussion and then set up a general outline for the day or a week. But most importantly, be flexible and adapt as things change. If you realize being flexible reduces stress on everyone, micromanaging your loved one is exhausting, not only for you, but it's frustrating for everyone involved. But note, as the disease progresses, you'll find more detail will be necessary and will not only benefit your loved one, but yourself, and in the future, certainly if you have in-home care providers, they also need a list of tasks and things to accomplish in the average day. So I want to show you a sample morning routine. We're looking at, just basic items that any of us can do. Wash up, get dressed, prepare breakfast, eat breakfast and take meds, discuss the news, brush your teeth, or just, activities, take a break with quiet time, do chores, get outdoors, take a walk. Early on in the disease and on a good day, your loved one may be able to accomplish several things on this list. Later on though, or maybe it's just a bad day for them, prioritize the essentials. What's important? Certainly meals, medication, brushing their teeth and some grooming. That may be all you can accomplish that day. But if you want to give it a try, do. If they determine that they're just not up for it, leave it be. Leave it for later in the day or leave it for another day. So now we're going to look at environmental strategies to support their independence. We've got an example here of a bathroom. Several items. Number one, ensure good lighting. Natural light is the best because it helps limit shadow and glare. If you have fluorescent lights in your home, see what you can do to have them replaced with full spectrum LEDs. Place a night light in the bathroom and on the path to the bathroom for visibility during nighttime bathroom visits. Reduce clutter. You need to be aware that there are many visual spatial deficits that are prominent in Lewy body. And that, along with the slowing of their cognitive processing, less in their environment is better. You might consider organizing and labeling drawers, cupboards, closets, and work areas. I've even known some families, they came up with this suggestion. And let's say your loved one has a very crowded closet with a lot of shoes and clothes. The families would take out an assortment of those clothes, box them, put them aside, then they'd cycle them back through the closet on a rotational basis. By reducing the number of items that their loved one needed to search through, they reduced confusion and frustration. The next is to avoid overstimulation. Take note of the current environment. Are you having to talk over background noise? Are you in a crowd of people? Are there children and animals running through the house? And obvious, as we all know, whether those could be real or they could be perceived. If you can adjust the environment by lowering the noise level or visual input, please do. If you can't, remove your loved one to a quiet space and allow them time to decompress. The other thing is to use color contrast. In this photo, you see the bathroom accessories in a contrast red. Individuals with Lewy body commonly experience visual deficits in 3 areas: depth perception, color perception, and contrast perception. They'll have a greater chance of discerning important objects in their environment if the items are contrasted. This is also true when they're eating. A white dinner plate and napkin on a white tablecloth, let's say you're serving cauliflower and chicken. It's a very neutral environment. They'll have a very difficult time seeing that. It all washes together in their visual field. But a red dinner plate, napkin on a white placemat with food, maybe in a variety of colors. It could be a bright salad. That's going to facilitate their ability to independently feed themselves for a longer period of time. And later on in our webinar, Sarah will share additional suggestions for color contrasting. Let's set up items that they need for their tasks. Let's say it's a cooking project. Is your loved one still able to follow a recipe? Can they find the ingredients in the cupboards? Do they still know how to use the stove and the oven? Why don't you consider laying out the ingredients in the order that they're to be added, along with each of the implements that are required throughout the recipe? You might offer just to preheat the oven for them. But as the disease progresses, please don't exclude them from the project, but consider just simplifying again. Take those additional steps to include them and simplify. You might also consider adaptive devices in the home and possibly even home modifications. Knowing which devices to obtain or modifications to make, you may require professional input. Talk with your loved one's primary care physician to see whether you have, through Medicare, you may be able to have a home safety evaluation performed. And if you're not on Medicare currently, determine whether your standard health plan will cover it. So if so, a physical or occupational therapist may come into the home and assess the safety going room to room. And they'll be making recommendations for improvement, some simple and maybe some more complex. If you aren't able to have a professional come in, we have provided a link at the end of this webinar to the Alzheimer's Association's home safety checklist. Next slide. So this is a really interesting slide. The issue of keeping security items readily available. I'm going to give you some examples. For many individuals, what we consider a secure item may be their eyeglasses, their phone, their purse or wallet, maybe their Bible or their prayer beads, maybe a magazine or a book. You'll get a sense of what is considered their security item as your loved one will start being incredibly protective or secretive of specific personal items. So you need to learn to store items in a consistent, accessible place. Again, that's like their schedule throughout the day, consistent. It might be in a drawer in the dresser or the nightstand, or it could be in a basket by the front door, or even you can create their special box, a place where they can kind of hide their special items and only you and they know where they're at. You may want to keep it next to your person's favorite hangout. Do they have a favorite chair and a table next to it? Or if they spend most of their time in their bedroom, consider just placing it on their nightstand. This is the most important thing. It has to do with the security of the security items. It's having backups for items that might be misplaced or, in their words, stolen. In my experience, the most important items to consider are eyeglasses, keys, purses, and wallets. With eyeglasses, keep a slightly outdated prescription as backup. You can pull it out when the newest is misplaced, and then you keep searching for the newest. Keep spare copies of all keys. Keep them in a very organized, secure location in the event that their primary set goes missing. If you have concerns that your loved one should no longer have a set of keys, you can always create what I term a dummy set. And that would be, pull together some old, unused, outdated keys and create their own set of keys. If it's their purse or wallet, early on, this is critical. Make certain that you have photocopies or documentation regarding all credit cards, IDs, and other important items that they keep in their wallet. It's essential that you have these documented in the event of any loss. But as their disease progresses, I know you and I both agree, we don't want credit cards lost or stolen. We don't want IDs taken. However, you can replace active credit cards with the outdated ones. What you need to know most is that your loved one needs that visual reassurance. That visual aspect of seeing the cards in their wallet can provide them important reassurance that their items have never been stolen. So the next slide talks about how we can interact with them using verbal, visual, and tactile cues. So if you look on, we'll see under verbal cues, we can use 1 to 2-step instructions or give them options, this one or that, now or later, or utilize yes or no questions. And I'll give you an example here. Early on, in addition to their slow mental processing, our loved ones lose their sequencing ability. They struggle to recall the sequence of actions necessary to complete a complex task, and as time goes on, simple tasks. Let me give you an example of verbal cueing that I was able to use with my sister. She'd frequently feel the urgency to go to the bathroom and would pop up and hurry to the entrance of the bathroom, and she'd just stop cold. She had no recall of the next steps. To allow her to toilet on her own, I'd utilize simple phrases and would pause, take a breath in between each phrase. Do you need to go to the bathroom, sis? Walk to the toilet. Turn to face me. Back up. Pull down pants. Pull down underwear. Sit down now. Relax. That's my example for today. You can utilize that in whatever manner you choose. Now with visual cues, demonstration is the best way to do it. Whether it's in grooming, dressing, or initiating, taking, visual cues work well in the moderate stages of the disease. To begin with, make certain that you're in your loved one's line of sight and make eye contact. Exhibit the action you want them to complete and encourage their participation. My sister would stand up from a recliner and not be able to initiate forward walking. So I would stand in front of her and I'd start swinging my arms and I'd take these grossly exaggerated steps like in a marching pattern. She'd start laughing because I looked so ridiculous, but then she'd slowly start to swing her arms and then we'd start marching together and she'd take off. And it became a fun action between the two of us. Now, the third way to communicate with them is to use a tactile cue. And the technique that we recommend is guiding their dominant hand with a hand-under-hand assistance. It can be utilized to assist them with eating, dressing, and grooming, especially brushing teeth. So after today's webinar, if you wish to learn the hand-over-hand technique, we've provided the link down below at Dementia Care Central. It's a video by dementia expert Teepa Snow. So there are other communication tips that I'd like you to focus on also. Focus on connecting with the person. If they're seated, sit with them and make eye contact. If they're standing, again, the important feature is making eye contact before proceeding with it, whether it be approaching or engaging or questioning. Set a positive mood with your tone and your body language. Remember that stress is palpable even across a room. A gentle voice and relaxed body language will help improve any situation. Take your time. Please don't rush. Allow double or more the amount of time to prepare for and accomplish a task. It will lower everyone's stress level. Use respectful humor. Please don't make your loved one or their actions the brunt of your humor. Say it's time to do something versus asking if they want to do it. Hey, honey, it's time for lunch. We'll get you a lot further on a bad day than, honey, would you like to eat lunch? And if it's not working, move on and try again later. Take a deep breath, walk away, count to 5. And if it's absolutely essential, fine, but please just revisit it later in the day. It's really not worth an argument. And if nothing else works, consider using rewards. Rewards can be, but don't always have to be treats. A lot of people say, oh, I'll give my husband an ice cream and he'll, or pudding, or we'll have a drink together, and that might improve the situation. I prefer a different approach. You could always just use verbal rewards. You could say, if we get this done now, we'll have enough time to go take that drive out in the country today. Or if you get dressed now, we'll have extra time to do your hair and makeup. Simple incentives are always the best. So let's look at ideas for in-home activities. I'm just going to cover, you can read the slide as I go on. Obviously, there are grooming activities. Exercise is the best daily activity I can recommend. Chores, simple chores, not physically taxing. Entertainment, recreation, relaxation, and animal therapy. Let me share with you the best advice I ever received from a healthcare provider in relationship to activities. He told me the best medicine for my loved one was to keep her both physically and socially engaged. That statement was the foundation for our activity decisions throughout the course of her 13 years. And I can tell you it made the greatest impact on her quality of life. While considering many of the items listed here as kind of in-home activities, once we get past the current COVID-19 crisis, they're always very adaptable to outdoor activities. But always remember that when you devise a schedule of activities, remember they're not for you necessarily, they're for the benefit of your loved one, and you can take pleasure in it as their supportive person. So, but I want you to take a very pragmatic approach to activities at home. Please pace yourself. Remember, this isn't a race to see how many things you and your loved one can accomplish in a day. This is going to be a long marathon that's going to stretch on for several years. So again, pace yourself. You're going to be dealing with apathy, decreased attention, and daytime sleepiness, as they are very common barriers to engagement. So on the days that your loved one is struggling with these barriers, they may only be able to accomplish the bare essentials, but on other days, you may be able to break through their fog by guiding them gently. Instead of asking, would you like to? Use, please join me, and begin the task, and again seek their involvement. And if they truly aren't interested, let it be for the current time. But also, if apathy and daytime sleepiness become a chronic issue, one that really seems insurmountable, really take the time to contact your loved one's physician about alternatives. In some cases, it may be necessary to introduce medications. But that is as a last resort. Plan for shorter, more frequent episodes of activity. Maybe 15 minutes is a long period of time. As the disease goes on, 5 minutes may be all they can handle, and a more realistic approach. Find ways to connect through activities of daily living. Simple again is best. Share the daily comics, have a good laugh, make the bed together. FaceTime with your grandkids. So I'm going to give you an example of how to simplify an activity. Here's a perfect example. We're going to utilize knitting. Now this slide kind of gives you step-by-step example of how to retain the pleasure of an activity as the disease progresses. The individual may lose the physical or mental capacity to perform the minute details of the task, but you can help them continue to enjoy the experience. So we look at knitting. So this gives them better tactile response, allowing the use of knitting with a simple pot holder with bigger needles and thicker yarn. Then it may be that you use one of those wooden looms that kids use. Later on, it's maybe just feeling the yarn, rolling it into a ball. Then you may just they may be best at just choosing the colors of the skeins and then having fun directing you, saying, no, you're not doing that right. I told you when you were a little girl, you did it this way. They may be able to just glue bits of yarn onto paper, or later on, just sitting with them and sharing books or a video about knitting. And then in the end, just to have a blanket that gives them some security and peace, but the feeling of that yarn in their fingers, that may be the best they can enjoy at that time. So.
Thank you, Helen. This
You're
is
welcome.
Sarah. I think we're all learning more about how to connect remotely using technology these days. And especially for those of us who don't live with the person that we're trying to help care for, or if we live with the person and are trying to connect with people who don't live with us. These are some tools that other people are using and we're learning to use as well. For a person who has a difficulty using a cell phone or smart device, there's technology that's designed for easier use. So the Amazon Alexa Show, you can program it with friends and family so that friends and family can drop in and have a video call without having the person have to pick up. There's also video monitoring technology that has some two-way audio, such as pretty basic, simple video baby monitors, or smart home devices like Nest cameras. So this is emerging technology, and the level of security and privacy that we have with these devices is something we're all learning more about, and it is a way for us to connect when we can't be together physically. Helen mentioned FaceTime for those who use Android devices. Google Duo is a video calling app. There's also Skype, or like we're using now, Zoom. Another piece of technology that we've learned about from caregivers is the Amazon Fire Stick TV, which has a little bit more capability in terms of remote control. You can actually use a smartphone app to control the programming remotely, and you still have to use whatever subscriptions that you have, so Netflix or Hulu or HBO or however you get TV, but you can also use things like YouTube, which actually has a lot of free programs that might be engaging for people. The next topic that we're going to discuss is fall prevention. So the CDC actually has data that shows that mortality has been increasing for older adults in general due to falls. From 2007 to 2016, the rates of mortality per 100,000 people has increased by 30%. So we don't really understand why that is, but it's just important to note that falls are a significant cause of death among older adults in general, and they're even more problematic for people with dementia, and particularly people with Lewy body dementia. So people with dementia are at higher risk for serious fall-related injuries. This is a study that looked at injury-related hospitalizations, and falls were the cause of the injury and among 90% of people with dementia. And they found that people with dementia were at higher risk for those more dangerous injuries like hip fractures and head injuries, and that they were less likely to have injuries like upper limb fractures. So they were less likely to try to protect themselves from a fall and break their wrist or arm, and more likely to have a more damaging injury due to falls. So it's really important that we do everything we can to prevent them. The other problem with falls, that as caregivers, falls are part of a cycle where it increased dependence. So even just psychologically, if someone falls, they can become more afraid of falling. And then it can be more difficult for them to cooperate with care and getting up to go to the bathroom, getting in and out of a car. They can become deconditioned because they move less and require more assistance with transfers. And it creates this cycle that basically makes it more difficult to care for them at home without lots of help. So why are people with Lewy body dementia more at risk for falls? Well, we have a lot of symptoms that contribute to this, and falls in general, there's usually not one thing that causes them. They're multifactorial, and so we want to consider everything that might contribute to falls. Specifically, symptoms from Lewy body dementia that contribute to falls are the mobility changes, the Parkinsonian mobility changes, problems with blood pressure regulation, so orthostatic hypotension that Dr. Manti mentioned in his webinar, urinary urgency, so really rushing to the bathroom, visual processing changes that Helen mentioned, and then also cognitive changes, so slowed thinking, slowed reaction time, decreased safety awareness, inattention, and impulsivity. So mobility changes that contribute to falls, the Parkinsonian movement changes are slowed movement, a shuffling gait, where people are more likely to trip, freezing. Helen described her sister standing up and not being able to get moving. So that's a common cause for falls in people with Parkinson's and Lewy body dementia. And then impaired balance. So we all, when we're standing, make minor adjustments in the way our weight is distributed to adjust for, to maintain an upright posture. And people with Parkinson's and Lewy body dementia lose their ability to maintain balance as well, and they can actually just spontaneously fall backwards. Here are some kind of fun and exciting videos actually to watch about strategies that people with Parkinson's use to get moving when they have freezing or mobility problems. Just to note that these are not strategies that necessarily prevent falls without, supervision and assistance, but might help get people moving and also demonstrate the mobility challenges that we see. Let's see if I can get this video to play. There's no audio, by the way. So this person has a shuffling gait, and now they're doing counting and marching. So you can see his movement is much improved. Skating movement. So this is shifting balance. And these are really, ways of tricking the brain into using different parts to help them move more successfully. So this is like skating movements, shifting their weight. Walking sideways. There's shuffling movement, trying to walk forward, feeling stuck. And when he shifts to sideways movement, he's more successful. Still at risk for falling with that. Okay, this one definitely don't necessarily recommend this at home. But you notice the pathways are nice and clear. There isn't a lot of clutter on the floor. Makes this a little bit safer. It is amazing the difference in mobility here. And for those who are hesitant or reluctant to use a walker because there's stigma around using a walker, this might be an alternative. There are walkers, the four-wheeled walkers and particularly U-step walkers have been more helpful in improving mobility of people with Lewy body dementia and Parkinson's. And that's the kind of fall that can happen with freezing. Some more shuffling gait. And this is a dual task exercise, kind of shifting attention to a rhythmic bouncing. Other families have found that things like listening to a real upbeat music, or as Helen said, just demonstrating marching and marching together can be helpful. Things like lasers can be helpful. I mentioned retropulsion. That's where people fall back and they're not able to correct their posture. So I found this website, University of Florida Health, where a physical therapist demonstrates a way to help someone get their weight forward. This is providing really tactile cues in a way to get their attention to not just telling them to get their weight forward. So the idea is to have them hold a big beach ball or some big object, and to focus on placing that object on the ground by bending their knees and sitting down in the process so you can see their weight is nice and forward. So if you were to reverse that and helping someone get up, bending over, people really do need to bend over really far forward to get their weight forward enough to stand easily. I think a lot of us aren't aware of that. So this is the kind of technique that a physical therapist might use to help someone overcome some of these challenges. There are programs in the community. Power for Life is a program designed for people with Parkinson's that people with Lewy body may be able to participate in, focusing on big movements. Dance for PD, it was developed by the Mark Morris Dance Company in New York. They have some resources at home. There's a lot of seated exercises that can help people with moving. And rock steady boxing has also been popular among some of our patients. So, but like Helen said, if a physical therapist is really going to be able to give you more personalized advice and recommendations, not just for tailored exercises and strategies, but also possibly for home modifications, assistive devices, and then also training on how to safely get up from a fall. So in some cases, falls might be like we can't prevent them. We just know that they're going to happen. And the best thing we can do is learn how to safely help someone up from a fall. So more about problems with blood pressure regulation as a fall risk in Lewy body dementia. Dr. Manti described orthostatic hypotension as being caused by a dysfunction in the autonomic nervous system. So the brain doesn't send the proper messages, so that blood pressure does not adjust normally when people change positions or with temperature changes. And it can cause pretty extreme fluctuations in a person's blood pressure. So their blood pressure can drop suddenly, and they may report feeling dizzy or weak, and they can have what I've heard some caregivers describe as leg crumbling falls, where they're standing there and their legs kind of crumble. They just kind of crumble to the ground. Common triggers for these types of falls are a sudden change of position. So typically getting out of bed in the morning, standing up impulsively if they're need to get to the bathroom suddenly, bending over to reach for an object, overheating if someone's trying to exercise or taking a shower that's too hot, or they're out and they get too hot and on a hot day. Standing for too long can just cause the blood to pool in the lower extremities. Eating a big meal, anything that, then the blood goes to the digestive system and you can get dizzy and fall. And sometimes even just straining on the toilet or sitting on the toilet for too long. So what we recommend that you do if the person has a fall or reports feeling dizzy or lightheaded is to talk to the person's doctor. You can ask for them to check their blood pressure, and you want to have them check it not just when they're sitting down, but also lying down and standing. You can consider purchasing an automatic blood pressure cuff for home blood pressure monitoring. And also reviewing medications. So there are medications that can make the symptoms worse if they're taking a blood pressure medication, or a mood or behavior medication can make falls worse. They can also be on a medication that might make them at higher risk for injury. So a lot of people are on blood thinners, and you might want to talk to the doctor about the safety of that medication if someone's having a lot of falls. There are also strategies that are generally recommended, but we would advise that you talk to the doctor about the safety for the person you're caring for, because they may have kidney or heart issues where, the fluid intake, you wouldn't want to just, go ahead and encourage fluids all day if that could cause other health problems. People can have other causes for bad circulation in their legs where they might not want to wear pressurized stockings, but that can be recommended. A lot of people don't use them even if they are recommended, because they can be challenging to put on. And then also increased salt intake, and sometimes people even end up on taking prescribed salt tablets. Again, that's working with your doctor. Other things that can help that you don't necessarily have to talk to a doctor about are just encouraging the person to sit on the edge of the bed for a few minutes before standing up, offering smaller, more frequent meals, avoiding large, heavy meals. And then if the person is reporting feeling dizzy or their blood pressure is low, help them to sit or lie down. That should help the symptoms go away and avoid a fall. And there are medications like fludrocortisone, I'm thinking, that are sometimes prescribed to help increase the blood pressure. Again, that's something you want to talk to the doctor about if these other more conservative measures don't help. So talking about the visual spatial deficits that can occur with Lewy body dementia, here's a normal clock draw, which is a common test used in people with cognitive changes. And here's an example of a clock draw from someone with visual spatial deficits and Lewy body dementia. So you can imagine how the way they're processing visual information is so different from the rest of us. As Helen mentioned, they often have problems with depth perception and spatial awareness. So things like doorways and rugs might provoke freezing. They may not be able to see the stairs. So using color contrasts or brightly colored tape on the edge of stairs can help them see the stairs. They might miss the bed or chair when sitting down. So that's something to observe for. They might need more supervision and cueing. You could also try to use color contrast with furniture to help make them more visible, or give them cues to wait until they feel the chair on the back of their legs before they sit down. Also, reaching for objects can compromise balance if they try to pick something up from the floor. So they also can have an inability to distinguish shapes, colors, shadow, and glares. They can have difficulty recognizing things, people, or places. And misperception can trigger hallucinations. So this is not necessarily directly related to falls, but certainly is something we want to avoid exacerbating for our loved ones. And reiterating the advice Helen gave earlier, decreasing clutter, particularly in pathways, considering color contrasts like brightly colored tape, having a colored toilet seat, grab bars, and shower bench, and avoiding high contrast patterns on carpet or flooring or other things that might be misperceived as a hole in the ground, like a dark mat in front of a doorway. You want to remove or secure rugs, improve lighting, and consider covering windows and mirrors if they're creating a lot of glare or distraction. And then you want to select sturdy chairs that have armrests that can be used to help people stand up, that are an appropriate seat height. So a lot of times people will have chairs or couches in particular that are too low and deep, and just make it harder for people to have to scoot forward and push, really get their weight forward to stand up. Here are more examples of color contrast. So you can see the way when everything is of a neutral tone, it can just get washed out. And likewise in the kitchen. I'm gonna kind of speed through here because I want to leave time for questions. So here's the Alzheimer's Association home safety checklist that Helen mentioned that's available to download and has a lot of useful tips, and also information from the CDC on postural hypotension. We'll give you more detailed information that for you, and also if you want to share it with people who are caring for your loved one who might be at risk for falls. The cognitive changes really are, I think, some of the hardest to try to accommodate, and really seems to require just more supervision, and sometimes, vigilant supervision. It can be a reason why people need more help in the home, or why it's becomes no longer safe for them to stay at home if they're having such frequent falls. But particularly around decreased safety awareness and impulsivity, we can try environmental modifications. If someone's getting up to go to the bathroom at night, can they use a urinal or a bedside commode? Sometimes hiring someone to help at night if that's a real problem, and also trying to decrease fluid intake and later in the day, and other strategies around toileting and urinary urgency. There might be medication to help with urinary urgency. One thing I will say that I have a lot of caution about, that I see families trying are the use of restraints. So, partial bedside rails can help people get in and out of bed, but a full bedside rail might actually be a higher risk, in that people can still try to get out of bed and might actually climb over the rail and injure themselves more than they otherwise would have. So, and I would I would opt for a more harm reduction approach, like putting the mattress on the floor or getting an extra low bed and maybe putting a mat on the side of the bed, removing furniture that they might hit their head on. And just, that they might still end up getting out of bed, but are less likely to be injured. Or there are alarms that can be used that don't necessarily alarm on the for the person, but if you're sleeping in separate beds, for example, the alarm can alarm near you to wake you up so that you can help them, but not necessarily. Sometimes the alarm can be so startling that it causes the person to fall, even though the intention is to prevent a fall. So alarms we think of as like really just notifying you that the person got up and they might have already fallen. Okay, so yes, talking to the doctor, asking them to review medications, especially blood pressure, medications for mood or behavioral symptoms. Sleep medications can exacerbate falls. And vitamin D, they might need their vitamin D level checked. If they're deficient vitamin D, that might help a little bit. And then requesting a referral for outpatient or in-home physical and occupational therapy. And also just to remember, it's a good idea to have the eyes and feet checked regularly. People can lose sensation in their feet, and to wear well-fitting shoes. So avoid slippers or high heels, and stick with shoes with sturdy soles and heel support. Here are the resources that we mentioned, and this will also be available on our website. We want to acknowledge the organizations who made these trainings possible. And now it's time for questions. So please type in questions on the bottom of your screen.
Great, thank you, Sarah and Helen, for that wonderful presentation. Very informative and helpful. I just wanted to reiterate that this webinar will be recorded and posted on our Memory and Aging Center website for those of you who are asking. While we wait for questions to come in, I thought I would ask one from you, Helen, since you talked about the importance of establishing a daily routine. And I was wondering if you have any guidance for caregivers who are caring for loved ones who have a lot of fluctuations with their cognition and mobility, and how fluctuations might pose a barrier to establishing a daily routine.
Well, I think most people, or at least, if they've just started their journey versus those of us that have been dealing with Lewy body for a long time, that's one of its core features is the fluctuation in cognition. And I'm talking, it can change as rapidly as every few minutes. Normally it's, a full day will be good and the next day may be poor. And I think flexibility and simplicity absolutely facilitate dealing with fluctuations. It really takes time to kind of determine the ebb and flow of your loved one and realizing what their capabilities are, not who they used to be, but how can you make it best for today. So I really believe that you need to observe and assess each day in its sections and as time goes on, and say, all right, today we're going to work on brushing our teeth and we're going to get our hair done, but we're not going to be able to take that walk around the block. And I really believe as a caregiver, we have to not lower our expectations, but not expect as much from them. We need to be focused on making them the best they can be, not what our needs and wants are.
Great, thank you. We have a question from a caregiver here who says it's difficult to get her husband to do any activities, and she says that his back hurts whenever they try. So do you have any suggestions on what might help?
In that particular area, I think with the back, that all of those features, especially the upper back if you notice in someone who walks who has a lot of Parkinsonianism, they have a stooped posture. And that can actually be addressed through the physician making a referral to physical therapy. The person needs to be working on core strengthening. Every day, my sister at 4 o'clock would go into massive spasms up into her neck, from her upper back, shoulders, and into her neck. We did moist heat therapy on her upper shoulders and back with just item we could put in the microwave to warm. We'd use massage. And then with the physician's approval, we just used over-the-counter ibuprofen to help reduce the inflammation in those muscles.
So I guess I would recommend, talking to the person's doctor, because there can be a lot of different causes for back pain. So we want to make sure that that's appropriately evaluated. In general, Tylenol is considered safer than ibuprofen for older adults, because ibuprofen is associated with GI bleeds and goes through the kidneys. So, and there's also topical things like Salonpas or lidocaine patches that can help with pain. But certainly if pain is a barrier to someone's quality of life and their daily function, it's important to have that evaluated and have a plan to address it, which would include, not just medication, but also, as Helen is saying, physical therapy and topical and other non-pharmacological approaches.
Great, thank you. And Sarah, I was wondering if you could talk a little bit about, what to do if a patient has an episode of orthostatic hypotension in the middle of their exercise. I've had some questions from caregivers where their loved one will be in the middle of a physical therapy session or in the middle of a rock steady boxing class, and will all of a sudden feel dizzy and feel like they're about to fall. So do you have any suggestions and tips on what might help?
Yeah, certainly talking to, if they're taking an organized class, most of these programs should be able to adapt for someone who might need to sit down for part of the class. So if they have a chair available, basically if you're feeling dizzy, you need to sit down or lie down because you're at risk for falling. And you need a way to be able to safely do that. So whether it's having a chair there available for you or someone there to assist you. And the other important things around, making sure that you're really hydrated before the class. If there's a way to increase ventilation, have a fan or something so that you don't get overheated. Those are the things that might help reduce it. And while vigorous exercise is great, and we encourage vigorous exercise, if it's too much for you and increasing your risk for falls, you might just need to cut down the intensity of the workout.
Great, thank you. And since we only have a couple minutes left, I thought we could end on talking a little bit about how maybe the disruption in routine because of this COVID-19 and because of the lockdown, what impact that might have on caregivers and their loved ones, and if both of you have any strategies or advice on what caregivers can do to help.
I was talking to someone the other day who had great advice. She said, you want to do your best and be gentle with yourself and take one day at a time. So I think, hopefully this is over soon. And, but, psychologically, we probably want to prepare ourselves for things lasting longer and just be gentle with ourselves. I think doing what we need to do for our own well-being so that our own stress doesn't become contagious for those around us. I think TV gets a bad rap, but we're probably all watching more TV than we otherwise would. And I think there are ways to engage with TV, watching something that helps bring up memories or something that you can laugh together about, something where you might learn something together.
Yeah.
It can be a shared experience.
Yeah, and I think for me, I know that over these last few weeks, I've reached out. I've refused to feel isolated, even though I am physically isolated, whether it be to pick up the phone or text or FaceTime with family members or friends I haven't spoken with in a while. I know that as a caregiver, isolation is something that just happens inherently, and we have to fight it. And this is a perfect example in time of our need to fight it. So reaching out to others and then saying, "Hey, next week, why don't you call me?" I think is really critical during this time.
Thank you. Thank you, Sarah and Helen, for your lovely talk. I'm sure a lot of caregivers found it really helpful. Thank you to everyone who tuned in to watch this webinar. Our next talk is going to be on April 28th, I believe, and the topic will be advocacy in community and healthcare settings. We hope to see you then. And in the meantime, take care, everyone, and stay safe.
Thank you.